Welcome and thank you for joining us today to the launch of the Cancer Care Report in Middle East and Africa. My name is Gertraud Eckart. I'm the Oncology Task Force lead in PhRMA, the Pharmaceutical Research and Manufacturers of America, and your moderator today. Before I'm going to introduce our esteemed panelists, two quick housekeeping items I would like to touch on. We look forward to an interactive session with you, so please send your comments and submit questions in the chat function. My colleague Marina is going to watch out for the content you want to share and cover, and will make sure that we are going to provide our answers. And let's get a bit active. We have hashtags in the chat you can use. Follow us and follow our speaker on social media, share, and feel free to report out of our meeting. And let me now welcome my co-host, Thomas Hofmarcher. He's the senior researcher at the Swedish Institute for Health Economics, IHE, and the driving force behind the Cancer Care Report we are going to speak about in a few instances. Together with IHE, we have been organizing this event to not only present the main findings of the report, but to also create awareness for the upcoming 2022 World Cancer Day on February 4. And Thomas, isn't it great to have such an international panel?
It's amazing, Gertraud. It's truly amazing. Also from me, a very warm welcome to everyone joining us live today. I already see over 100 participants logged in. It's fantastic.
That's great to hear. And so on behalf of IHE and PhRMA, let me now formally welcome Her Royal Highness Princess Dina Mired from Jordan. She's the immediate past president of the Union for International Cancer Control and has a number of high-profile international roles, including the honorary president of the Harvard University Global Task Force for Expanded Access to Cancer Control and Cancer Care in Developing Countries. Princess Dina has received many awards and is a strong advocate in the fight against cancer. Princess Dina, it's an honor having you with us today. Still missing, but she is about to dial in from the US, is Fadia Saadah, World Bank's Human Development Director for Europe and Central Asia. In her previous role, she spearheaded one of the most significant modernization and efforts, including the introduction of the first new financing instrument in over 30 years in the World Bank. Today, she will share with us her wealth of experience in the healthcare sector in low and middle income countries. We also have Ahmed Hassan Abdelaziz. He's Associate Professor of Clinical Oncology in Cairo and member of the Supreme Committee for the Egyptian Breast Cancer Program. And probably more important for us today, he substantially contributed to the IHE report. Welcome, Ahmed, and I'm happy to have you with us. And last but certainly not least, let me welcome the Executive Director of PhRMA, Samir Khalil. It's lovely to have you, Samir. And would you like to start with the formal opening of our event?
Thank you so much. And Your Royal Highness, and other colleagues on the panel and attendees, it's my honor and pleasure to be here today. On behalf of Pharmaceutical Research and Manufacturers of America, PhRMA, and our regional oncology working group led by Gertraud and other colleagues, it's a pleasure to be here. It's a great opportunity for us to discuss. PhRMA, as you know, represents the leading global innovative biopharmaceutical companies. These companies are on the forefront always, on the forefront lines of research and development of innovative medicines and vaccines. We have witnessed over the last 2 years the great work from our companies on COVID-19 vaccines and therapeutics that so hopefully is helping the world to emerge from COVID-19 and return our life to a sense of normality. These innovative medicines coming out of our research labs will not only cure diseases, but also improve the quality of life and productivity and survival of patients around the globe. In addition, our industry can be a key factor in the economic growth of countries. And that's the message I give it to countries in order to invest in innovation and to attract investment in innovation, particularly in clinical trials. That growth that is based on knowledge and innovation, which is more sustainable. Cancer is one of the most widely discussed health policy issues globally and becoming the second biggest cause of disease burden in the 9 ME countries, included in the report that is being launched today. The third cause of death, 1,000. I'm glad that the and Africa Oncology Work Plan and Excuse webinar and to learn about the current state of cancer care in Middle East and Africa. Developed by the Swedish Institute for Health Economics, it reflects on major trends in cancer across the region, including patient outcomes, disease burden, and patient access to care and treatment. Support and work with the cancer community, ensure that everyone facing a cancer diagnosis in Middle East and Africa is able to benefit from optimal treatment and care. In countries all over the globe, is the disease burden caused by cancer, both on individual healthcare systems. On the upside, significant scientific advancement have been made in recent decades, leading to improved diagnosis and treatment of cancer and better patient outcomes. Thanks to the scientific progress, survival is improving, giving many people a chance to live longer with better quality of life. Advances in cancer treatments have helped to improve 5-year metastatic skin cancer survival from 5% to over 50% over the past decade. Yet there's a long way to go. And most of our companies are so focusing on oncology and cancer research. Lack of access to the constant inflow of innovative diagnostic and treatment modalities remains a major challenge that needs to be addressed. These 9 countries involved in the report or addressed in the report comprise around 300 million people with diverse economic terms. Newly diagnosed cancer cases might almost double from 410,000 to 720,000 cases per year between 2020 and 2024 due to the expected demographic development. Policymakers need to prepare the health systems for this. Adequate planning followed by effective measures are needed to address the already considerable and steady increasing disease burden of cancer. Also to address the economic burden as well, which affect costs related to the healthcare resources used for cancer and indirect costs related to productivity loss. This great industry has always the obligation to engage with policymakers about the key policies and enabling factors for investment by our industry, particularly in clinical trials and research, and the access of patients. The most important thing is the access of patients to these innovations and invention that comes out from our labs. Therefore, I hope the team as a whole will be able to put together after this webinar a robust engagement and advocacy plan that involves all our companies as it is our collective responsibility to engage with policymakers for the benefits of patients and countries' health and wealth. Thank you very much for the opportunity again, and it's a pleasure to be here.
Many, many thanks, Khalil. You raised some valuable points, and apologies to the audience for the technical glitches a bit, the weak line. I think Samir had quite some meetings already today, and the line might be a bit worn out. So apologies for this. You raised quite some content, hurdles, inequality, and access to cancer care. I think this is something, Princess Dina, that's familiar with you, right? And you've been working in this cancer space for quite some time already. You've been engaged. And one of the latest functions in UICC, as we learned already, where inequity is at the center of a newly developed campaign. So if you would like to talk a bit about this campaign, what the strategic objective is, why you're dealing with inequality, inequity, and access, what's behind it, and what outcome would you like to see in this broad engagement?
Thank you so much. I would like to share with you my perspectives, first of all, as a mother of a cancer survivor, also as a former Director General of the King Hussein Cancer Foundation in my country, Jordan, and also as the immediate past president of the Union for International Control. And the reason, I value this journey so much, I have learned and I'm able to share with you, from a patient perspective, as a carer to my son, from being part of the team that actually changed the narrative of cancer care in my own country and have actually witnessed at a grassroots level the barriers that we're going to be talking about that actually stops access to cancer care, and in a low middle income setting, as well as the global perspective, having been the president-elect and president from 2016 to 2020, traveling 50 times in those years, I've really seen a lot of the commonalities of the barriers all over the world. As we speak today, we still talk about, the 2020 statistics, they talk about 19.3 million cancer cases, new cancer cases, and 10 million deaths per year. Unfortunately, we still talk about 70% of those deaths in low middle income countries. And this deadly statistic, as I call it, is totally unacceptable. And of course, developing countries are reaping, they are the ones who are being affected mostly about the lack of cancer care. But however, as we have seen, especially during Corona times, which has exposed so many faults in our health systems, we have seen that there's also inequity of being able to access cancer care, not only in low middle income countries, even though they have the lion's share, but also in high income countries, within countries where you really don't expect and you don't understand why are we losing those precious lives unnecessarily? What are the issues? And that is why I'm very proud as past president of UICC that we have finally decided to dedicate 3 years campaign to close the care gap. And in 2022, this year on World Cancer Day, February the 4th, I think it is very apt to say it's very important to talk about these barriers as to why we still have those deadly statistics affecting developing and people in high income countries. Some are very obvious, but some are quite hidden, and we really need to realize the problem so we can tackle the problem. Access to quality care, I find it's a very complex issue. People, when you talk about it in academic terms, you almost think, oh, all you have to do is walk into a hospital and there you are, pay the bill and you've got quality care, cancer care. But actually, I always liken it to an Olympic hurdle race, actually. You've got your, whether you have, first of all, you've got your cultural barriers. That alone is a huge barrier, and I will dissect it further during my talk. Then, of course, you've got the lack of cancer infrastructure barrier. You know, for example, in developing world, you know, you still have to have the actual healthcare primary healthcare centers that are able to refer you. Whether you have a cancer treatment facility near you, and whether it's a qualitative cancer treatment facility. That's another issue, because we all know cancer knows no mediocrity. And then, of course, whether you have the, you know, you come across, you have a fantastic cancer center, can you pay for it? You've got the financial barriers ahead of you. Do you have health insurance? And if not, we all know, I always say, you know, if you are poor and have cancer, it equals catastrophic. It's a catastrophe. Then, of course, geographical barriers, and so on and so forth. So there are lots and lots of issues. For example, certainly in low middle income countries, you've got the lack of cancer infrastructure. And here we're not just talking about the actual buildings, which of course you need, and it costs lots of money. You need the machinery, you need the radiotherapy machines. I've visited countries in Africa where they've had they've only just procured, believe it or not, the first ever radiotherapy machine to service, for example, 40 million people. It's crazy. So you've got that, you've got the machinery, you've got also, you know, the medicines, let alone innovative targeted medication. That's another story that they don't have. Lack of a clinical trial infrastructure, which you've talked about. Also lack of skilled workforce. So this whole cancer infrastructure, a lot of low middle income countries don't have. And quite frankly, it's really been because of the divide and the competition between diseases, between communicable and non-communicable. Let us be reminded it was only in 2011, September 2011, that actually the UN has finally added the NCD acronym in its million of one acronyms, right? Finally, the global denial has been put aside, and finally they gave space to non-communicable diseases. And as a result, many and low middle income countries with, you know, the high income countries focusing only on communicable, everything else got delayed. And that's, I would say, one of the main reasons why 70% are dying in low middle income countries, but that's not the whole story. Then, of course, you know, included in low middle income countries and in high income countries, you've got the cultural issues, and they are huge. For example, you've got gender norm and discrimination as a barrier. You know, around the world, women and girls suffer, for example, from discrimination, either as a result of misogyny, stereotypes, expected gender roles, etc. Certainly in my country, some women, you know, they need approval from the husband to go and visit a health center or to go and do an early detection test. So that is an access. Even if you have the best cancer center down the world, that is a real barrier. Also, men can face effects of gender discrimination and societal and cultural taboos. For example, you know, many men with this whole definition of masculinity may make them less wanting to discuss health concerns or consider certain life-saving procedures, etc. That is a real barrier. Then, of course, you've got barriers for minority populations. You know, in New Zealand, for example, Maori people are twice as likely to die from cancer as a non-Maori. You know, we need to understand why is that. Certainly minorities, indigenous people living in over 90 countries are supposed to represent about 6% of the world population. They also account for 15% of the extreme poor. Again, could this be is because, you know, given that they have discrimination, potentially poverty, of course, leads to, for example, them, maybe minorities or indigenous people being exposed to more poor nutrition, more high-risk factors such as alcohol, substance abuse, drugs, etc. for cancer. These things are real and they are a barrier, and that's why we are seeing people not having the chance to get the same level of care for cancer and same outcomes because of this. Poverty, of course, you know, transport. I know when I was Director General of the King Hussein Cancer Foundation, we had covered a little boy for leukemia. We had a donation of $100,000 ready for that boy. And he had started treatment and he was responding. Suddenly, he stopped coming, only to find out that the family didn't have the fare for the taxi to come every day. And that's when we started our transport program. These are real things. People, and this leads us to the rural-urban divide. That's another barrier. Traveling, not having the same services that you would have in a sort of capital city, right? Interrupted treatment, and so on. Then, of course, you've also got cancer and aging. You know, more than 70% of deaths caused by prostate cancer occur in men over 75 who usually have more aggressive disease. And yet, few older patients, you know, they receive, few of them receive treatment for localized prostate cancer. And even some are denied access. There is this sense of ageism, they're too old. You know, this is something we need to take stock of. Refugees, that's another thing. You know, when I was the DG of King Hussein Cancer Foundation, we had the Iraqi refugees and we had the Syrian refugees. And when I turned to the UN system to see what is there available to help treat refugees for cancer, there was nothing. And if there was something, it was minimal. And I witnessed it personally, you know, and we had to make donations ourselves as an NGO to help cover the cost of refugees. So, and if you do find them, they also are presenting very late when you know chances for cure is minimal. Then, of course, you've got homophobia, transphobia, the related discrimination. You know, they also have a barrier to coming for cancer care. And people are saying they're more likely to receive, not to go to those treatment centers because they fear discrimination and bad behavior towards them. And on top of that, they may face depression and so on, and actually seek high risk behavior that will actually bring on cancer and other NCDs. So this year, we need to take stock, we need to realize the problem so we can tackle it. And I hope everyone will join World Cancer Day and, you know, show add your voice, because we need to ask world leaders and the global health community to, when they do design policies, to put in the foundational principles that have to be in this policy. And equity is one of them. And that's the only way to help close the care gap. Thank you.
Thank you so much. There was such a rich content. We could cover days until the World Cancer Day. I think we could talk for days. You touched on so many things, Fadia. You most probably are very familiar with, right? It's ending extreme poverty and increasing equity is the twin goals of the World Bank Group and you belong to. And we know, and Princess Dina mentioned it already, we see 10 million people die of cancer yearly. And we know that this number is going to double in the next 20 years. On the other hand, we see that interventions we have might be ready to treat or prevent many cancers. So from a WHO report 2022 on cancer, we know that 7 million of these deaths could be prevented if patients would have access to these interventions that are value-based treatments, health system strengthening. Fadia, this is something you've been dealing with in the World Bank as well. How can we make sure that these interventions come to a nation and are accessible for patients? How can we make sure that investment in healthcare and cancer care is prioritized? What does the World Bank, how does the World Bank play in there and your expertise? I'm happy to get your thoughts on this.
Thank you, and thank you for including me in this panel and this important discussion. I'm really pleased to be here today because I think what we're discussing today stands to be the issue of the decade, if not decades to come, because of the increase in non-communicable diseases and the aging in the world, as well as all the factors my previous speaker spoke about. So this is really a very timely issue. But before going to that, I also want to take a moment to congratulate Dr. Hofmarcher and the team for an excellent piece of work. What I liked, and this is a context for the discussion, is that you've highlighted 3 key messages. One on the relationship between investments and survival, right? And this is really something we always strive to do as any country or any policymaker, to really show tangible results, and these investments can lead results. So we know solutions are available, at least to some of the issues. Second is the comprehensiveness and the many entry points to this. So this is very contextual. As Princess Dina mentioned, this is really something that changes from place to place, country to country. So this multiplicity of entry point and sort of comprehensiveness helps policymakers to see how best they can address it. And thirdly, I'm very pleased to see the focus on inequality in this discussion, because this is at the heart of the matter. And we have unfortunately seen inequalities been rising before, and with COVID, we've seen it even get worse because of the access to care. So this is not only timely across all health issues, it's very timely also for NCDs as well. It's hard to know how much to cover given the breadth of the discussion. Let me highlight a few messages that I take away and I hope to share. First, it's the recognition of the scale and the potential policy intervention is key. I think Dr. Samir mentioned that earlier, and quoting the WHO report, is about the scale for the Middle East region. In my job at the World Bank, I actually cover Europe and Central Asia. So I was reading the report, and from my personal experience, I do see how large the program and how growing it is. And it's something that really a waste. It doesn't have to be this bad. And that's sort of the motivation for action. As mentioned, the cases are likely to double, but we also know that there are very high levels of avoidable risk factors in the region, especially smoking, obesity, some of the behavioral aspect, and some of the health policies. So there are a lot that can be done. Just to highlight with you, it's always good to look at country examples. In Egypt, we see that the issues of cancer, breast cancer in women, and how high it is, and how high it is in the lower income level, and really the level of inequality and the level of the outcomes. It is very disturbing to observe. I looked at the cases in Jordan and Lebanon, and I don't need to look at the books for that. I'm Lebanese nationally, so you see so many cases that are increasing. It is, and with the catastrophic of the economic and the refugee situation, it's really getting worse. In Saudi, with all the access for very good care, we see a lot of inequalities actually as well in the cancer treatment across the board. The second message I would like to stress is actually cancer care is going to redefine and should redesign health systems as part of a long-term smart strategy for delivering care. We can no longer define health systems that do not have NCDs at the core of it. This is common across all spectrum of countries. We see it probably more in some than others, but even the poorer countries are having the dual burden of disease. So it's not something that's just middle income countries or higher income countries are dealing with. This is across the board. And it is really part of our wider pursuit for universal health coverage. So we cannot do that without really looking at NCD and NCD services. In fact, in many of our programs, whether in Asia, where I've worked more in Asia, and Europe, more or less so in the Middle East, unfortunately, but a lot of the time, a lot of effort we're investing into help countries reorient their health systems to really incorporate and integrate NCDs in every aspect of healthcare. We have access to selected cost-effective, so the message on that is invest today, actually, and don't wait, because we know a lot of the investments that work. We know the cost at this cost. I looked at one statistics in South Africa, I think in 2018, and this is a bit dated, the care, direct and indirect cost is 6% of health expenditures just for cancer. Now, that could have really saved a lot of lives if we had really detected cancer early and gone after that. So invest now is the first message. We access and select the cost-effective interventions. We have a whole range of literature and history about that. We also have many countries that are looking at national cancer control plans as a way to deal with this, to look to enable early detection, to look at reduced cost, to look at the areas that really help. But we do still find, as the previous speakers mentioned, that many are presenting very late and they are really not benefiting from it. And so we're losing lives and we're losing resources, and we're burdening a health system that's already fatigued by dealing with very extreme cases, which is suffering on all fronts, from the patient to the provider to the financing, which is really unnecessary and not warranted. So let's think about designing health systems that address NCDs hand in hand as we pursue universal health coverage. If you look at the data for this region that we talk about today, actually the universal health coverage varies from 17% only in South Africa to 100% coverage in some of the Gulf countries. So the range is very wide. So it's still a big agenda. But the comprehensiveness of the benefit packages, even for those offering universal health coverage, doesn't always include preventive measures, doesn't always look at detection. And that's it's such a waste, honestly. I'm trying to find the right word because it makes you a bit angry because it is smart for all. And yet they pay you sometimes for the treatment, but you cannot do the pap smear or you cannot do the mammogram because that's prevention. And so it's not even included, even those who have the luxury of having such access to the benefit package or having private health insurance, because universal health coverage or more of the model of health insurance systems that are available in Europe are not as common in the Middle East and in these kind of regions, countries. So we need to do that. Out-of-pocket payment that countries and individuals are dealing with are not only high, but driving a lot of families to poverty. So that's a multiplier of the impact of cancer care. And we see very high out-of-pocket payments because of the lack of financial support and financial stability there or coverage. Inequality in the region can be addressed by simple measures. We have to just at least start to try address it by the governance, which is addressed in the report quite well. And to have some of the key measures by trying to really include some of the things that are available in primary healthcare that could also include NCDs. So that could take a bite at the inequality. It's not going to solve the whole problem, but even within what we have, if we can integrate some of these that could try to help address the gap. Setting up infrastructure was discussed earlier, but here I want to flag a couple of things. One is what to choose in the infrastructure. That's the tough policy choice, and that is important that we have the body and the governance to really address that. I haven't seen many ministries of health in the region that systematically do that, but maybe this is an area that could be developed and could grow. Now, I don't blame them because I know they have many things that they are dealing with, but at the same time, really, we need to raise awareness about this issue. What are the best interventions? How can you access it, etc.? But also, what are the mechanisms to introduce novel technologies? That's another cause of inequality and also sometimes a huge cost. We all want to have the latest technologies, but which ones to choose and how best to introduce it? There are techniques that many countries now are adopting to have sort of, again, somehow governance and contracts that introduce this in a systematic way that's thought through, that's rational, where the government may decide to introduce it and they first take some of the cost burden of the patients, or later on to expand it or to start selectively or to send it widely, depending on the country context. But this cannot be just, with due respect, I'm speaking to pharma people, but I always like to provoke a little bit. It's not just because the pharma team came out and made a good case for it. There has to be a bit more thinking about what the implications for this. Who should get it? How do we access it? How do we make it, if it works, accessible to many? So this process is important to go through. And we talked about the resource implication that the previous two speakers. So increasing the fiscal space is critical. And it cannot be more critical than now, because with COVID, we've seen the impact on the economy, on the people, and the shrinking fiscal space for even basic services. We've also seen that many people forgo treatment because of COVID. So there's a backlog on one hand, and there's also a lot of constraint on the fiscal space. So we are trying at least to make sure that we make the case for the priorities for some of the basic services, that including health and education and other things. Those have to be preserved when we think of sort of shrinking fiscal space. But at the same time, there are things like the sin tax we talked about in a previous seminar, I believe, on tobacco, on sugar products, on other things, which we have used effectively in many countries, and some countries in the regions have tried to use it as well, but it can be provide a lot more. Just to give you an example, recently we did this in Armenia, and they increased the tax on tobacco from 17 to 75%. They basically project this will reduce smoking by 32% in terms of preventable and avert 33,000 deaths over the years. So this is actually a win-win to everybody, except the tobacco companies probably. But this is really an area where we can do more, where we can also target those savings to address some of the inequities, to address some of the needs in the health system and other areas. I just want to close by saying it's not all gloom and doom. There are things that work, and we've seen good examples. So there are areas, if you look across, we've seen in Egypt, there are diagnostic centers, that they are really clinics, that they have integrated care, one-stop shop. That's a very good example. It may not cover as many as we like, but it is actually a very good potential. Jordan, I think the Princess Dina covered the issue on King Hussein Cancer Center and others. We need more of that in the region. We look at, in South Africa, they have a cancer registries, another very good example, which we can build on. The syntax in some countries that have done it, but I think I will put my voice for people to do more of that. And of course, Egypt also has been looking a lot at the liver cancer with hepatitis C, and they have a big national plan. So it can be done, and I hope that they can do more. And thank you again.
Thank you so much. Rich again, Thomas, I think most of the things we hear now from Fadia was part of the research bit you did in the past 1.5 years with the more than 30 experts. And perhaps we go now quickly into the IG report as such, and you're going to share with us a bit the key findings. What was the reason? Why do we do this report, the outcome, and what would you like actually to see should happen now?
Yeah, thank you very much for this. It's great to have had some two excellent speakers before me that have already covered many of the things that we have written about in the report, and that I would not even be able to cover now in this event. But the basic idea behind the report was really to prepare a comparative analysis of the state of cancer in the Middle East and Africa, and we looked at 9 countries in particular. South Africa, in the south of Africa, going up then to Morocco, Algeria, Egypt, Lebanon, Jordan, and also Saudi Arabia, Kuwait, and the United Arab Emirates. So these 9 countries we looked at, we compared with each other, also to some examples from Europe in order to get another benchmark from a different regions. And I have to say, I was joined by a great team of co-authors, of course, but most of all, over 30 local experts in all of these 9 countries have supported our analysis and helped us really understand and describe the situation on the ground. And we are forever thankful to those experts. Now, here on this slide, you see what has already been said. The challenge with cancer is expected to grow in the coming decades. So between 2020 and 2040, those 20 years, we expect almost a doubling of the number of new cancer cases. That's a major challenge that needs to be addressed. And there are measures to avert some of this development, but it's really critical to take action now. Next slide, please. And even though you might feel that it is challenging, the situation is challenging, no doubt about that, but there's also some silver lining that I would like to draw your attention to, and that's called the demographic window of opportunity that we see in the Middle East and Africa. Because demographic trends are super important. They explain why we see or expect to see an increase in the number of cancer cases. You see here in red, the people aged 65 and older. Cancer is very much concentrated among those people. That proportion of the population is expected to grow. So that's one of the major driving forces behind the increasing incidence numbers. But what we also see is that the orange bars, the people in working age, are quite stable or even growing. And that sort of development, that sort of window that we have now in the next 20 years is really favorable for building a strong economy where you have people of working age being able to work, join the workforce, pay taxes. And that sort of tax revenue creates budget room to invest in healthcare and then also in cancer care. And those investments trying to improve the health of people will also reinforce the economy, because healthy people are more productive than sick people. So what's really important to understand, and we really hope that we can get this message across, is that public spending on healthcare and on cancer care is not just a cost, but it's really an investment in the population, in society. Next slide, please. And what's also important is to understand that cancer is not just one disease. We're actually fighting multiple diseases. When we look at men, it's prostate cancer, lung cancer, liver cancer, colorectal cancer that are the most common cancer types. In women in the region, it's really breast cancer, followed by cervical cancer. And all of these cancer types need different approaches, how we tackle them in terms of prevention, early diagnosis, and treatment. So that's also important to keep in mind. On the next slide, I'm going back again then to the idea that even though there are multiple subtypes of cancer, we really need a comprehensive approach how to tackle cancer. There are 4 key areas of cancer control. First one is prevention, and second one, early detection, which aim to reduce the risk of getting cancer. Early detection is then also part, as well as diagnosis and treatment and survivorship, of trying to improve cancer survival and the quality of life of cancer survivors. But besides these 4 key areas of cancer control, what's important is the 5th area underneath, governance. Someone has to coordinate all these tasks along what you could call the patient pathway. That's critical. Next slide, please. So what's really decisive here when it comes to governance is to make the fight against cancer a political priority. And there are very good examples from other parts of the world. President Nixon in the US declared the war on cancer in 1971, and that was really a turning point 50 years ago in the US. In Europe, last year, we got Europe's Beating Cancer Plan, launched by President Ursula von der Leyen, which hopefully will also mark a turning point of how we deal with cancer. And both of those are examples of sort of what the WHO nowadays recommends countries to do, namely to implement national cancer control programs in order to be sure you're tackling the disease in a comprehensive way. That being said, national cancer control programs probably are not always a silver bullet. That's something that was clear in the report when we talked to the local experts, because many of the countries that we analyzed actually have already national cancer control programs. But the key thing is not just to write a paper. The key thing is to implement all the actions that are defined on that piece of paper. That's what matters. Next slide, please. So the general steps to improve cancer care, the way we see it and try to emphasize it in the report, is really, number 1, to measure and understand the magnitude and development of the disease burden of cancer. I think this fits very nicely into the initiative by the UICC. Here, the IHE report really presents best available evidence for the 9 countries. The second step is then to plan, coordinate, and implement both financial and non-financial actions to address cancer, ideally along the lines of a national cancer control program. And what the IHE report adds is really 20 to 30 specific recommendations for each and every country for all those different areas of cancer control. So we have really been looking very, very carefully on how to best tackle cancer depending on the country setting. And then the third step is to monitor and to evaluate actions on cancer control. Because if you want to invest money, if you want or work, you have to be sure that it really makes a difference for patients. In order to know that, we need information, we need data, And for that, cancer registries are important. And this is really also a key area of development in all of these countries in order to really improve cancer registration. And on my final slide, I'd just like to reiterate something that we've already heard, cooperation. That was the key to writing this report. We could try to cooperate with patients' organization, talk to physicians, industry, approach government officials. We really try to involve everyone in each and every country in order to be able to understand the situation and provide good recommendations. But what I would like to emphasize is this is also the job of the Ministry of Health in the years forward. Try to really involve all relevant stakeholders, bring them around the table, make them talk to each other, and try to decide on the best way forward, the best way to benefit cancer patients in the coming years and decades. So thank you very much for that.
Many thanks, Thomas, for putting this comprehensive report in, I think it was 6 slides, or was it 5 slides? It was already a task, but we had, as you said rightly, our co-panelists covering quite some content already. So I think we are good with this. The report and the 9 country profiles for all the people in the audience, we have the link. It's publicly available in the chat function. It's going to be translated into French, so there will be a French version available by end of month. So I think that was the first time that we are going to translate into a foreign language other than English. And with this, I'm moving on a bit now to our expert, the one actually who is dealing with cancer patients on a daily basis. Ahmed, this is you. And we saw in the presentation, measure and understand the magnitude of cancer burden and acknowledge that it is a challenge. This is nothing I have to tell you, because this is how you spent your life already. How can we tackle this part? And you coming in from a country with your expertise now, when it comes to this planning and coordination, Thomas mentioned it, evaluation part, what's the main hurdle? How can we make cancer really addressable, tangible, accessible?
Right. Thanks, Gertraud. It's a pleasure being amongst these esteemed faculty. Well, you know, statistics in my country say that every 5 minutes we lose a life for cancer. So that is, by the end of this session, we will lose roughly 12 to 15 patients. So we don't want to sit here in a year's time or in 2024, 2025, and we discuss challenges and barriers and this and that. I mean, the report Tom has just summarized has really very nicely dissected and detailed the barriers, the milestones, the efforts, and all of that. But we need to take this to the next step, into a real tangible action plan. And to have this and to see noticeable outcomes, to see a product, you need a sustainable and a scientifically backed up roadmap, together with support from the public, the media, and a political support as well. And I cannot emphasize more on the latter one, governmental support. I mean, Thomas has hinted on that before, but in this particular part of the world, to overcome the many hurdles, the challenges, the red routine, so many obstacles can be easily facilitated and overcome by the support from the governments and the Ministry of Health and the politicians. So you really need these on your side. And I'll give you a very, very clear example. Hepatitis C. Hepatitis C has been endemic in Egypt. It has been harvesting the souls of thousands, if not millions, over the past 7 decades, killing many Egyptians. And we all knew about hepatitis. We all knew about the disease. We all knew about the treatments. But when there was a true, sincere political intention to eradicate this, and when we had really radical plan, scientifically backed up, we had a very wonderful plan in 2018. We managed to screen 50 million Egyptians in less than a year. And they were successful in curing 2 million Egyptians from hepatitis C with cure rates of 90%. This is a success story. Of course, cancer is more complicated. Cancer is different than hepatitis. But I'm saying that if you have sincere efforts, if you have science, if you have evidence-based medicine, and you have good intentions, sustainable plans, then you can do something and you can see results. So we need really an action plan, and we need to execute it very soon. We have seen also starting to witness some results from the National Breast Cancer Campaign. This was launched 2 years ago. And of course, it is too premature to comment or give some results on cure rates or survival figures, because these will take years and decades to see. But we have seen over 2 years how you can downstage cancer, how you can bring the stage 3 and 4 in breast cancer from 60% to 29%, right, by improving awareness, increasing focus on the screening program, making it more accessible, particularly in remote areas. So we need to invest a lot in that. Cancer is something that you can see really tangible results if you have a clear plan, a sustainable plan, a practical plan, if you can reorder your priorities. I mean, money and finance is definitely part of the equation, but trust me, if you reallocate the resources wisely, that you can transform the survival outcomes and you can cure so many lives than what we're doing today. So indeed, the report, it was a very valuable tool. I'm sure it will help policymakers in this part of the world, but we need to see some action.
That was a brilliant ending, actually. We need to see some action is one of the best sentences one should end, but we don't end. We have another 6 minutes. And Marina, thank you very much for the statement. Ahmed, we switch now quickly. Questions in the chat. Is there something?
Yes, we have one question for Princess Dina. How can individuals or small organizations contribute to the UICC campaign to make it impactful over the next 3 years? You are muted, Princess Dina. Sorry.
Actually, not just small organizations, the whole premise of the campaign that as individuals, organizations, everybody can do something. Whether you do a fundraiser and you share it in the campaign, so other organizations can share about the impact of your fundraising campaign, for example, put out awareness, write a letter to your MP, make an activity, whatever it is that you can make, advocate, whatever you do is going to make something. And I know each campaign we've had thousands and thousands of activities, and the beauty about it is people can learn from each other, countries can learn from each other to see if a certain campaign or certain activity did really make an impact. So don't be shy. Anybody can make something, from a child to an adult to an organization. You just add your voice, because the more this World Cancer Day becomes loud and huge, the more we have clout. And we absolutely need it, especially after Corona. We have a lot of catch up to do. So this World Cancer Day campaign, I wanted to break records.
I'm not sure if we're breaking records right now. I'm trying to keep the time and not to break the records. Thank you so much. And I think we have quite some audience. Contribute, be on social media, be active. As said, we can do with every support in this matter. Any more questions, Marina? We can take another.
A question for Thomas. Cancer planning and delivery of cancer care is heavy lifting. What would be a recommendation for governments to kick off the actions?
Yeah, so I mean, in the 9 countries that we looked at, we actually have, I would say, 2 good examples, and probably not the ones that you would expect. You probably would expect it's maybe welfare countries on the Arabian Peninsula, but it's actually Morocco is a very good example where key stakeholders have been cooperating on a cancer plan. They had one for 2010 to 2020, and now a new one for 2020 to 2030. And the first one was very successful. They really tried to be comprehensive, address different areas of cancer care, and also include a funding plan for all planned actions, because that makes it easier to actually to implement all the actions and not just write it down on a piece of paper. But when you add a price tag, it's easier also to communicate it to the Ministry of Finance, and simply have this this element of accountability. That's important.
Thank you, Thomas. Any suggestion from you, Dr. Ahmed, about this question as well?
Sorry, say it again, Marina.
Any contribution from you to this question as well? I can repeat it.
Well, I wanted again to highlight on something that is very crucial that Tom referred to earlier, and that is, which is a culture that is really, we are lacking in this part in the developing countries in general and in the Middle East in particular, and that is the clinical governance. When I lecture in oncology congresses or conferences, I always try to bring this into attention, because you can improve the results of the healthcare even without introducing new technologies or new fancy medications or expensive systemic therapies, by just improving what you already have, monitoring the services, doing some sort of audit, quality assurance, quality control, ensure safety nets, capturing patients from being forgotten, things like these, and improving the whole process and the patient access without introducing new services. You can improve the results. So I was very happy to see Tom and his team adding this, working in parallel to the 4 blocks of service improvement. So I cannot emphasize more on the importance of that.
Thank you so much. Being mindful of time, and I'm awfully sorry, this hour just flew. I'm thinking of next year, and I thought of this campaign, the lovely campaign of World Cancer Day. There's the 2023 element, and we look into the future. And this is something I would like to do with a quick final round next year, same day. What would you like see has happened in this region? 1 sentence each. Take out your crystal balls. Ahmed, would you like to start?
Right. First, I would not want to hear about COVID or variants, all right? Secondly, I would like to see more people aware of healthy lifestyle, abstaining from smoking and adopting more healthy lifestyle. This will be a quick thing to see short-term outcomes.
Thank you. Fadia, what would be your wish? And I know you told me in the briefing call we had, one shouldn't wish for things that might come true. So perhaps a good one.
Well, I'm Lebanese. I think I have a long list of wishes for my country. So, but I really hope in the region, at least, to make prevention mandatory in all healthcare packages and health financing and health insurance. It's really sad to see that most of the time it's focused only on curative care. So, thank you.
Thank you so much, Fadia. Thomas.
Well, I really hope that there is at least one high official in every Ministry of Health that picks up our report, or at least the summary sheet, and thinks it's helpful, insightful, and provokes some thinking, and moves cancer up the policy agenda in the Ministry of Health.
That's a great wish. And dear audience, this is something where you could help us with. Her Royal Highness, the Princess, last in our statement, something good to take away?
I just want to reiterate that, cancer itself is a comprehensive disease. It makes sure to stealthily make actions to steal our lives and create havoc in a comprehensive way. Therefore, we should act comprehensively. And I would say countries in our region, cancer control plans, which should include from prevention, early detection, treatment, palliative care, survivorship, etc. That's the only way. And I agree with Thomas, it should be costed cancer control plans that should be implemented. And definitely one quick win is stop tobacco in our region. That's one thing. Tobacco alone could reduce so much lost lives.
There's nothing more to add to this. It was all brilliant. All I can do is to thank you and to thank as well, not you only as a speaker, thanks to the audience for staying with us, spending the hour with us. And I would like to mention 3 people in the background that helped us. The one you see on the screen, Marina, then there was lovely support from the Rock Bank, your assistants, Fadia, that were really tremendous. Janine from the from the UICC team responsible for the campaign. So not to forget all the busy bees, Asil and Miranda from PhRMA, that helped us making this event happen. We are going to be back next year. I'm planning already heavily, so I hope you will stay tuned and please follow us on social media. Help us raise the voice, follow the campaign, and let's get next year something action happen, and then we see and come back and evaluate what we've done. Thank you all for this lovely hour. I enjoyed it tremendously. Have a lovely day and a lovely evening wherever you are.
Thank you so much.
Thank you so much.